sir. You can please start with your presentation.
Okay, so this talk is meant for postgraduates. I'm just going to start off with a question, if anyone can answer. Among the 4 things which I've mentioned here, which do you think is the most challenging when it comes to pediatric anesthesia? Anyone? Yes, sir. Number one, okay. Number 1. Anyone else would differ? Number 4, okay. Number 4, okay. Anyone else? Any other answers? 4. I think all of them are challenging. I think it depends on who the anesthetist is, who the patient is. Okay. But personally, for me, I think I'm a pain specialist as well. So I think pain management is the most complex thing in children, and it's quite underreported and undermanaged. But all 4 are quite significantly difficult in children compared to adult patients. So I'm going to try and make this talk more practical. So I'm not going to be talking about things from the books. Try and things which I think is relevant clinically. So children have quite different aspects in terms of physiology, anatomy, psychology, and so they are challenging in very different ways. But compared to adult patients, you don't find hypertension, diabetes in children, ischemic heart disease. So they are easy that way, but they can be difficult from the other aspects. And unlike adults, you could have a child who's 2-month-old, a 2-week-old, or a 2-year-old, or a 16-year-old. So it's a very diverse age group. So when you're doing a pediatric list, you might have to keep changing your equipments according to the weight of the child. Now, when it comes to risk categorization of pediatrics, there are some factors which make them more prone for complications. So one is the age of the child, which makes a big difference. Smaller the age, higher the risk. So in most studies across the world, they've shown that children less than 1 year have the highest risk, and obviously neonates have the very high risk. Second is obviously type of surgery. I think most of the deaths in children occurs in cardiac surgeries or in emergency surgeries, and sometimes in neonates. It's other thing which has been shown is if a complex surgery is done in a pediatric center, the complications are less compared to a center where it does everything. So complex surgeries are better done in a pediatric center where all of them are tuned to how to manage kids. Experience of the anesthetist, yes, that also makes a difference. And anesthesia outside the OR also has a higher risk, and it's more challenging. And one study showed that an anesthetist who does less than 100 cases per annum, okay, there's an increased risk of complications when he does kids. So this data, I think way back in 2015. So in this, they've classified based on the World Bank high income, middle income, and low income. India is a lower middle income country as per the World Bank. So you see that the complication rate is highest in neonates, followed by less than 1 year, and the other age group follows after that. And compared to the middle income countries, higher income countries have a lesser mortality and morbidity. Having said that, we don't have much data. If you see the data here, it's only 62,000 from middle income countries. High income is very high. So again, we cannot compare that. But age-wise, I think there's a clear demarcation. Less than 1 year has a very high risk. So in adults, we do mainly anesthetic practice in theaters. Okay, very rarely we go outside theaters, but in children, we do spend a lot of time outside theaters. Typically, we're called for things like anesthesia for MRI, for CT, for PET scan, and IV access is something which we get called repeatedly, very often, maybe twice or thrice a day, because we are a pediatric center. So we do get a lot of IV access calls. Sometimes arterial line, central line, ICU, and for transferring sick patients, we get called. Now, this part of the assessment is very important. The preoperative assessment is the first time when you see a child and the parent. So there are certain things you need to look at specifically for kids. One is obviously the airway, because airway is going to be one of the major factors which can cause complications. So look for factors which cause increase in airway hyperreactivity. Typically, a child who's had a recent URI, children with asthma, children with multiple allergies, all of these can have a high risk of complications when it comes to airway management. Snoring, again, it can be a marker of an obstructive airway disease. And finally, loose teeth again, this can be tricky because sometimes you find a teeth in the chest X-ray post-operatively, or yeah, that can be something which is you have to be specifically considerate when you do kids. Look for IV access, the ease of IV access when you see a child preoperatively. There are some scoring systems for that. Caudal space, one of the most common blocks we do in children. So assess the caudal space. And when you look at a child, you can clearly say whether they're fit or unfit. Child is running around, crying, looks normal. But when you see a child, sometimes some children, they could have a very dysmorphic facies, they could have large ears, they could have a microtia, limb abnormalities, polydactyly. All these children can sort of, when you have these external markers, they could have internal abnormalities as well. So when they have one abnormality, look for other abnormality. Typically look for cardiac defects. And we have a separate spectrum of disease called autism spectrum disorder. These are again children who can be quite difficult to manage because they cannot communicate. That's a different group, and they can be more challenging. Okay, one common exam question is if a child has URI, will you proceed with the surgery? So again, a simple URI, no, but there are some indicators. When a child has fever, lung signs, child doesn't look normal, raised white cell count, child is not feeding well. So all these are indicators that not a good idea to go ahead with surgery. And murmur, again, it's a very commonly heard finding in children, but there are some certain features which can indicate that you need to refer to a cardiologist for further workup. So a child with symptoms like difficulty in feeding, interrupted feeding, changing color with feeding, an abnormal murmur, which is a diastolic murmur or a thrill with a murmur, failure to thrive. All these are indications where a murmur could be significant, so you need to investigate further. So that's something which a cutaneous marker. So when you have such a thing like a patch, a hemangioma, a tuft of hair, or a dimple, it could indicate underlying spinal dysraphism. So basically, when you're trying to do a caudal in these situations, just be careful. One is it's better to do an ultrasound guided caudal or avoid a caudal. Look for alternative technique to block the area. So when we see a child, sometimes there are 5 people coming along with a child. Yeah, you have a parent, grandparent. So sometimes you might have to spend a lot of time answering questions, dealing with the anxiety of the parents, and so on. Always ask for whether they've had previous admissions for medical or for surgical, because again, the child's anxiety levels can significantly change depending on what they've had previously in terms of experience, how pleasant or how unpleasant it was. A child who spent time in the NICU, okay, earlier, they have some special considerations. One is IV access can be difficult. That's one. Second is if they've had a mechanical ventilation in an NICU, there's a small chance they could have an increased risk of subglottic stenosis. So have a tube size which is smaller than normal. And thirdly, very important point is anyone who spent time in the NICU are likely to have a long-lasting decrease in the pain threshold. Okay, during the neonatal age, when they are subjected to multiple painful interventions in the NICU, it seems to have a significant, a permanent change in the pain threshold for many years to come. So studies have shown that children who have spent time in the NICU, they react with more distress even for a vaccine injection compared to someone who's not spent time in the NICU. So that's a very important point you need to be aware of. Okay, what do you tell the parents? NPO, again, this is something which we repeatedly fail. Even we tell them, again, they feed the child. So always check if the child is fed before taking them inside the OR. Consent, yes, you need to tell them about whatever you're going to do. ED stands for emergence delirium. So I'm sure people who have done children will have seen this complication. How many of you have seen emergence delirium in the recovery? Yeah, so it can be, if a parent has not been told this issue, when they see them for the first time with emergence delirium, they're quite shocked. They ask, what is happening, doctor? What is happening, doctor? So if you tell them before that the child could wake up very restless and can thrash around a lot, so at least they can anticipate this problem. Your common questions: when can my child start eating and drinking? Always inform about ambulating a caudal after a caudal, because there could be some amount of motor weakness, so they could fall. So just be careful about it. Tell about what medications you're going to give for pain, And in a child who can make choices, for example, a child more than 8, 9 years of age, they will understand what you tell. So in these children, try and explain what they will go through over the course of the periodic period, and give them a choice. Okay, if they want mask induction, give them mask induction. If they don't want a mask induction, they want a needle, fine, give them a needle. So it's always better to give the child the choice of decision making. Otherwise, they feel good when they make decisions. Yeah. Okay, very important point. When you have a very small child, particularly a neonate or a sick child, don't hesitate to have one more anesthetist with you. Okay, children can sort of crash so quickly if you don't establish an airway. So things can happen with alarming rapidity in small children. So if you're not comfortable, if you don't do children regularly, have help in hand. Okay, before you take a patient inside OR, always try and introduce yourself, because it could be one anesthetist who does the pre-op and it could be you anesthetizing the child. So, and always ask the parents for final questions before you take them in. Reassure them, and yeah, check NPO status before you take them in. Pre-medication, there are some clues where I normally give pharmacological pre-medication. So when you see a child in the preoperative assessment area, child doesn't make eye contact with you, child doesn't want to be examined, cries a lot, doesn't come near you, okay? So all these indications with that, they will not respond to sort of distraction techniques. You will have to use pharmacological pre-medication to sedate them and take them inside OR. And generally for children and for parents, the most curious aspect of anesthesia is, one is separation anxiety. So you can't drag a child forcefully from the parent and take them inside the OR. As much as possible, try and avoid doing that, okay? Because that can affect the psyche quite significantly. Next time, they don't believe you, and the moment they see a healthcare professional, they will just run away. Yeah. So one is separation from parents. So if you think the child will not come with you, sedate them. That's one. IV cannulation, obviously, very, very frightening for children. And lastly, the mask induction. Again, that can be quite scary for children. So EMLA for children before IV cannulation, and commonly we use triclofos and dexmedetomidine as a pre-medication. Triclofos orally, dexmed 2 mics per kilogram nasally. Okay, prepare the theta according to the patient's age and weight. So different equipments, different monitor settings. And at least in our hospital, we always keep an ampule of succinylcholine and atropine ready. Induction. So PPIA is parental presence at induction of anesthesia. Again, this can be a double-edged sword, okay? If a parent is anxious, don't have them. Okay, if a parent is anxious, don't have them. They will pass on the anxiety to the child, okay? On the other hand, if you think a parent will pacify the child, will make them accept a mask induction, have them. Again, in our hospital, we have a separate room for induction for very anxious children, or children who cannot come inside the OR, or who are not willing for pre-medication and so on. So you can use them outside along with the parent, but if the parent is anxious, they start crying the moment you sort of see the child, don't have the parent, okay? And when you take, if you have a child who thinks is cooperative, you take them inside the OR, you tell them you're going to give a mask induction, it's going to smell a little bit, okay? And use some distraction techniques. There are phones available, cartoons available, videos available. But when you take them inside the OR, minimize the number of people inside the OR, okay? Don't have too many people, don't have noises happening, nurses opening trolleys, no sounds, keep it quiet, keep it warm. They will accept the mask. Again, give them a choice. Most children, if you ask them a question, do you want to lie down or do you want to sit and have the mask? They will say, I want to sit and have the mask. Okay? They feel vulnerable when they lie down. I don't know why. So, yeah, so sit and do the mask induction. And again, have help in hand if you think the IV access is difficult. What is this? Anyone has seen this? All centers doing pediatric anesthesia should have this. This is the intraosseous access. This is it's a drill actually. You can do access within a few seconds. Okay. In an emergency, this will help. So yeah, difficult IV access. That's a scoring system. If it's difficult, there are other sites you can look at. That's something which I have in our hospital. Transilluminator is very useful. It's saved us in so many situations. Some areas where you can look for less than 6 months scalp veins, external jugular vein, great saphenous vein. Great saphenous vein in the popliteal fossa is again one place where we've had success when no other site is visible. In children less than 3 months of age, maybe 6 months of age, apart from the routine access, we have this brachiocephalic vein cannulation, which is quite useful, quite easy. So that's something which you should try. There are multiple literature available. So airway management in children, again, if you can, don't intubate them. If they need support with the airway, LMA is better. If you think a child is going to have issues, then always try to intubate. When you intubate or when you try and laryngoscopy, try and minimize the number of attempts because they tend to swell up or bleed very easily compared to adult patients. So minimize the number of attempts to less than 2. If you don't get it, just call for help or stop your technique. Okay, try a different technique, call a different person, have some extra gadget like a video laryngoscope and so on. And co-oxygenation is very important in again neonates where they can desaturate very quickly. Okay, children have a anatomical difficult airway. All of us know that. Okay, they also have a physiological difficult airway. Why? Because their apnea tolerance is quite less because of a lower FRC, higher closing capacity, and higher oxygen consumption, higher CO2 production. All these make them very quickly they can desaturate in the presence of an apneic time. Okay, so when in doubt, always intubate a child. Okay, don't leave it to LMA or a mask. Okay. And during extubation, when in doubt, do not extubate. Okay, if you think the child may not sort of withstand, might obstruct that extubation, don't extubate. So wait for clear signs for extubation, and it's always better to err on the smaller size tube than a larger size tube. And there's something called a microcuff tube. How many of you have used microcuff tube here? Okay, and again, this concept of functional airway obstruction is very common in children. This is typically indicates things like laryngospasm, which happens at extubation. Okay, that's the microcuff tube. Oh, that's loud. It's very loud now. Okay, that's a microcuff tube. So if you see the microcuff tube, the cuff is placed closer to the tip of the tube, and there is no Murphy's eye. Okay, and the other characteristics, mainly because the cuff sealing pressure is less, so the less damage to the mucosa, and the cuff is made up of something called polyurethane, unlike the conventional, which is made up of polyvinyl chloride. So the narrowest part of the children's airway is below the vocal cords. Okay, when you inflate a cuff, a conventional cuff, it tends to inflate at the level of the narrowest part, unlike a microcuff tube, which tends to inflate lower than the narrowest part. So that's one of the reasons why they say the damage is less with a microcuff tube. Okay, question. Which among the four has the lowest pain threshold? 1, 2, 3, or 4? Anyone from the back, postgraduates? We've got 3 minutes to go. Come on. Who feels the highest pain given the same amount of noxious stimuli? Okay, sir knows too much, so okay, so 1 is the correct answer. Smaller the child, higher the pain threshold. There are various reasons why it is. I don't have time to go through it, but so you need to be very aggressive with a neonate having surgery. Okay, so lesser the age, more aggressive the pain management should be. Pain assessment is going to be challenging because you have this non-verbal age group or children with impaired cognition. So in these children, you have different scales to objectively measure the pain. Regional anesthesia, again, children have smaller nerves, closely spaced nodes of Ranvier, and lack of myelination. So you can block a nerve quite well with just 0.08 to 0.1% ropivacaine. Use ultrasound wherever possible, and high risk of LAST because of all these issues. Other problems is, they're more prone for hypothermia, PONV, and there are a lot of pharmacokinetic differences which can dictate how you tend to give drugs. Again, it's in aviation industry, it is shown that most complications occur during landing. Likewise, even in pediatric anesthesia, most complications occur during extubation. Classical one is laryngospasm. Okay, so that's why we have Scolin ready. And to prevent laryngospasm, there are various techniques. One thing which I commonly use is a small dose of propofol, 1 milligram per kg, 5 minutes before extubation. It tends to decrease the risk of laryngospasm, tends to decrease the risk of emergent delirium in the ICU, in the PACU. And if possible, extubate deep. Some people extubate with some SIBO on, okay? And one other thing which I do in children who I think might go for airway reactivity like laryngospasm, do a preemptive CPAP. So give a jaw thrust, CPAP, half closed apial valve. That will also tend to decrease the risk of laryngospasm. Okay, recovery position, do this for all children, okay, because the risk of airway obstruction is high. Very common thing in children less than 7 years of age, between 2 and 7 years is very common. They have this emergence delirium. So the main thing you need to look at is the child will not make eye contact and they will not respond to parental consolation. So if they don't get consoled by the parents, no eye contact, usually it's emergence delirium. It usually settles by itself. But if they're very difficult, trying to move lines, thrashing around, you might have to sedate them. Okay, the one on the right side, drug doses, is a very useful app to know. Click of a button, you get doses in milligram per kg. And the one on the right, all eponymous syndromes you can get information from. So summary, pediatrics is a very diverse age group. Okay, there are multiple challenges. Airway could be an issue. Pain management has to be aggressive. And emergence anesthesia is more challenging than the intubation. And never hesitate to have help or get help if required. If you're interested, there are a couple of fellowship programs in the country. One is the IAPA fellowships for 1 year. And last year, the DNB has started a 2 years postdoctoral fellowship in National Board. I think 8 centers have been approved. So you have information on the net if you require. Thank you.